Good afternoon, everyone, and welcome to today's Public Health Ontario Microbiology Rounds presentation on prenatal and pediatric hepatitis B virus and hepatitis C virus, room to improve the cascade of care. So my name is Melissa, and I'm a clinical microbiologist at Public Health Ontario, and today I have the pleasure of moderating today's session. So I just wanted to give you a little bit of a heads up. I am currently in Africa and my internet is not always at its best. So if I do go off camera, that is why, because I need to save a little bit of bandwidth. So before we begin today's presentation, I'll mention a few housekeeping items. So the chat pod has been disabled to limit any distractions during the presentation. Please use the Q&A pod if you have any questions during the session. A discussion and question period will follow Mia's Dr. Bionde's presentation. And if at any point during the session you experience any technical issues, please email capacitybuilding@ohapp.ca. I would like to state that as the moderator of this session, I do not have any potential conflicts of interest to declare. So it is now my pleasure to introduce the speaker for today's presentation, Dr. Mia Bionde. She received her PhD in microbiology and immunology from McGill University and completed her clinical training at Western University. She is also an assistant professor at York University and oversees the nurse practitioner program. Mia continues to practice as a primary care NP with focused practices in viral hepatitis, HIV prevention, and working with trafficked persons. Her research focuses on increasing hepatitis B, C, and HIV screening and treatment through alternative diagnostic and systems approaches. So I'd like to give a really big warm welcome to Mia.
Thank you so much, Melissa, and thank you to Public Health Ontario for the invitation to speak today. It's my absolute pleasure and privilege to be here with you. So I'm going to spend about 45 minutes discussing some areas where there have been gaps demonstrated in both the prenatal and pediatric cascade of care for hepatitis B and C. And I'm just going to start by going through my disclosures. So these are my disclosures, and some of my consulting fees actually do go ahead and pay for some of my research program, as well as some of the affiliated events with being a nurse practitioner coordinator at York. These are my objectives today, so I won't go through them, but we will hopefully touch on each and every one of them. And then just to start off by reviewing viral hepatitis. So as you're familiar, there's A through E that we commonly refer to, and of course there are others, but just as a reminder, hepatitis A is transmitted fecal orally, there is a vaccine available, our diagnostic tests are typically serology, and there is no treatment that's not home or hospital supportive care. Most people are asymptomatic for hepatitis A. Hepatitis B, also most people are asymptomatic. Major routes of transmission are blood, semen, and vaginal fluid. As you know, there's a vaccine available, and our testing is serological to start and nucleic acid to follow, and there are treatments to keep viral load at bay. Hep D, which often people forget about, is a co-infection that only occurs in the presence of hepatitis B, as far as we know. And there are some exciting new treatments coming out for hepatitis D. Hep E, which you're probably also familiar with, also an acute viral infection, transmitted fecal orally, no vaccine. Serology is the main way to detect, and again, no specific treatments outside of home or hospital supportive care. And then finally, hepatitis C virus, which is blood-blood contact. Despite decades of work, there is still no vaccine. Our major ways of testing is antibody to look for exposure, and nucleic acid or hepatitis C RNA to look for infection. We used to use interferon, but no more. We have excellent all oral, well-tolerated hepatitis C direct-acting antivirals. So I'm going to start off with the presentation by just commenting that the World Health Organization, or the WHO, actually called for the elimination of viral hepatitis by 2030. And this is just a graph showing that although many infections, which we think of as global health infections such as HIV, malaria, and tuberculosis, have consistently been going down and are projected to still go down. However, chronic hepatitis B and C are projected to continue to go up. And so Canada actually signed on to this elimination by 2030 of viral hepatitis. And there is some urgency. So everything I'm going to talk about today are really ways to meet this need by filling gaps in our current cascade of care. This is work that we did with Public Health Ontario labs, just to show the impact of hepatitis B and C testing during the pandemic. And what you can see is that at the height of the first wave of the COVID-19 pandemic, Hep B and Hep C testing significantly dropped. We completed this study in the spring of 2021, so our data only goes until that place, which is the third wave of the pandemic. But what you can see is at that point, testing did not rebound to pre-pandemic levels. So for those of you who are not in the field, hepatitis B and hepatitis C pre-treatment, the steps that people must take to get there can be numerous. So someone might need to see a clinician, and yes, that could be by phone or it could be virtual, but still that appointment needs to happen to request testing or for the clinician to offer testing. This person often has to go to the lab, come back for the results, and then do additional diagnostics such as other blood draws, potentially doing a fiber scan, potentially getting an ultrasound, depending on what their labs show. And this is all prior to individuals starting hepatitis B or C treatment. Now, some community providers might not be comfortable with various aspects of treatment or diagnosis, and so they might refer to a tertiary care hospital or a community specialist. However, each and every one of these steps has the potential to lead to loss to follow-up. And for those affected by hepatitis B and hepatitis C, specifically in Canada, these can be huge barriers. Now, we've done a lot of work to try to eliminate some of these barriers, like community outreach through point of care testing, dried blood spots, which Public Health Ontario has implemented, and we are the only province to universally implement this, which is excellent. There's many outreach staff who are doing blood draws on the street, in the back of a car, in shelters. We have really good nurse-led models. However, during the pandemic, each one of these steps, as I showed with the testing data, has been hugely impacted and not returned to pre-pandemic levels. So I'm going to start to talk about prenatal care. And I really like this image because it really shows that, moms and women and folks who are pregnant are often multitaskers. And this is even more so in the populations most affected by hepatitis B and C. So there's a lot going on in people's lives that can impact their ability to go through that pre-treatment cascade of care. And as much as we're speaking about the cascade of care for hepatitis B and C, I also just want to remind you that seeking prenatal care can also lead to multiple steps and multiple places for loss to follow-up. So someone might start with a home pregnancy test that's positive. And now what? Well, if they have a primary care provider, hopefully they're able to book an appointment with them. But as you probably are aware, we have a primary care crisis in Canada. And so many people might wait 4 weeks, 8 weeks for that first prenatal appointment. What about when people don't have a primary care provider? How do they even approach seeking prenatal care? So some communities in Ontario have self-referral obstetrical programs. Some midwives will accept self-referrals. However, they often require confirmation of pregnancy through blood work and an ultrasound. Some people have to go to a walk-in just for the purpose of getting a referral for prenatal care. And what's been shown is each and every one of these steps is more complicated when someone identifies as a newcomer or immigrant, is incarcerated, is an adolescent, or other specific scenarios that greatly affect those affected by hepatitis B and C. And there's actually been some really interesting data about this. So as far as inadequate prenatal care across the country goes, although some provinces like Nova Scotia are probably doing better than others, you can see that no province is doing extremely well in adequate prenatal care. And people need care, and they need care in an acute way as well. So people have symptoms in pregnancy like nausea and vomiting, and they can't wait 4 weeks to see their primary care provider. They have to go to multiple appointments. So every 4 weeks, then every 2 weeks, then every week. And especially for first-time moms, this is incredibly overwhelming. They might also wait in specialty practices for 3 to 5 hours for their appointment. They have to go for multiple tests, so blood work, ultrasound, And all of this, again, complicates the cascade of care and the ease for which people can have adequate prenatal care in Ontario. So there's actually been some really good research about this. In Canada, there are approximately 370,000 births every single year. And in 2019, a study was published that showed that only 3/4 of individuals actually have an optimally timed first ultrasound. So this was a really good measurement of adequate prenatal care. That's not great. And in the context of those affected by hepatitis B and C, who are potentially vulnerable, they're actually really motivated to seek prenatal care. So they want to have a healthy and safe pregnancy for themselves, for their potential infant. They want to remain with the child following birth, so they're doing everything they can to have a safe and healthy pregnancy. They're looking for support and assistance. This could be social supports, acquiring things that they'll need during the early months of the individual or the child's life. And they're really motivated to seek action. So they want to attend prenatal appointments, but there's barriers like transit and waiting. They're looking for stable housing or housing upgrades. They're really motivated to seek additional services to prepare for the birth of the child. They want to address violence in their lives, like verbal, physical, and sexual abuse. They're motivated to get involved with recovery and trauma programs, as well as OAT or opioid agonist therapy programs. And then for those that are affected by the justice system, there is a model for restorative justice so that individuals who are incarcerated during pregnancy can remain with their child following labor and delivery and birth. Okay, so that's sort of my prenatal spiel. I'm going to jump back to the viral side just for a few moments and speak specifically about hepatitis B, then the cascade for B, and then C and the cascade for C. So hepatitis B, as you're aware, affects 250 million people across the globe and is responsible for close to 1 million deaths due to advanced liver disease, cirrhosis, hepatocellular carcinoma. Certainly in places like Sub-Saharan Africa and East Asian countries, the predominant route is still prenatal transmission. So vertical transmission, or as the WHO calls it, mother to child transmission, is still the main route for pediatric infection in these countries. However, in places like Canada, most are acquired through injection drug use or high-risk sexual behavior. And then there's an exception that I'm going to speak about. Just as a reminder about the virology of hepatitis B, this is a double-stranded DNA virus. It's a circular genome, and it's thought to integrate into the host genome. Hepatitis B is very infectious. So when we think about the potential for vertical or horizontal transmission, things like daycares or close contacts when you're living, sharing nail clippers, tweezers, toothbrushes, children biting each other in daycare. These are all things to consider because hepatitis B is highly infectious. These are from the Canadian guidelines for hepatitis B screening, and I won't go through all of them, but we are supposed to be screening household contacts of carriers, meaning household contacts of those who we know have hepatitis B. However, we cannot screen people as household contacts if we don't know that individuals have hepatitis B. We talked about drug use, incarceration. All pregnant women are currently universally screened for not just hepatitis B, but HIV, hepatitis B, syphilis, and a few other things. But all pregnant women should be universally screened for hepatitis B. And then those who have immunosuppression and other situations where they might be immunocompromised. So in Ontario, Ontario is one of 5 provinces that actually doesn't provide hepatitis B vaccination until adolescence. So many of you joining this session today, it's actually started universally the year I was in grade 7. So I was in grade 7 in 1997, so I'm showing my age. And from that point onwards, everyone was universally vaccinated in adolescence. And prior to that, it was a little bit more sporadic. Now, as I mentioned, we're one of 5 provinces who do that. So what do the other provinces do? Well, the other provinces do either birth dose or infant vaccination. And this is because as of 2009, the WHO actually suggested and recommended that all countries, like Canada, universally vaccinate at birth. So a couple of assumptions as to why we may but not be universally vaccinating. So NACI actually recommends that each individual region, jurisdiction, or province look at their data to determine what the best mechanism of vaccination would be. So here are some assumptions that we're making in Ontario. We're assuming that all pregnant women are universally screened for hepatitis B. And I'll talk about some of the data about that. We're assuming that when the mom is known to be positive, that children are getting HBV, so hepatitis B immunoglobulin, plus 3 doses of the vaccination. So that would decrease their risk significantly of acquiring hepatitis B through vertical transmission. Now, what we're not remembering is that not all pregnant women might be screened universally for hepatitis B, but also there is something to consider about other close contacts in the family, such as dads, grandparents, and other caregivers who might be around this child. We also, when we identify a woman who is positive for Hep B, should be doing hepatitis B DNA testing in follow-up in order to see if they would qualify or be eligible for what's called third trimester antivirals. So not so dissimilar from vertical transmission in HIV, giving women antivirals who have high viral loads in the third trimester can greatly decrease the potential for vertical transmission. When we think about hepatitis B transmission generally and who should be vaccinated, it's very important to acknowledge that currently using an adolescent vaccination strategy, we are assuming that most children's contacts will be through sexual contact following their adolescent vaccination. However, it is important to remember that we actually don't have good data around children getting 3 doses of vaccination or HBV following birth because we don't have a centralized vaccine database. I also just want to mention that Ontario continues to be the major destination hub for many individuals across the globe, especially those who have HBV endemicity. So what do we currently know about the prenatal hepatitis B cascade of care? And the common cascade of care just means following people along from screening to diagnosis to linkage to care to treatment and potentially cure. So this is some work that we published in 2020. And what we currently know is that while screening is good, it is not universal in pregnancy. So it's only 93%. We also looked at this by LIN, Local Health Integration Network, and showed that the North region of Toronto has by far the highest prevalence of 1.51% in pregnancy. And this was done over five or 6 years. The overall prevalence of hepatitis B in pregnancy over this time frame was 0.63%. And just as a comparison, HIV in this same study was 0.03%, so 20-fold lower than hepatitis B. So as I mentioned, it's really important that when women are positive for surface antigen in pregnancy, that there's an immediate hepatitis B DNA ordered. This is to better understand how high the viral load is, the risk of transmission, and whether women would qualify for third trimester antivirals. Only 40% of women had appropriate follow-up testing. So this was HBV DNA testing in that pregnancy. And because prevalence of HBV DNA is higher when women are of childbearing potential, it's an evolutionary mechanism of the virus, most women were positive, so 96%. There is another screening test that we do to look at the potential for transmission. It's called hepatitis B E antigen testing. It was significantly lower at 13%. So that's screening. So far we know testing is not universal and follow-up testing is poor. Now, we did a little bit of modeling with this. So we also looked at how many women in this group were higher than the viral load of 200,000 IUs per ml, which would allow them to receive third trimester antivirals. And what we modeled based on our data is that because we're not doing appropriate HBV DNA testing, about 100 women every year actually are missing out on third trimester antivirals. And I should just say, I'm saying women, but of course, not every individual who is pregnant will identify as a woman. But for ease of this discussion, I will use the term women. So what about children? In this same study, we actually wanted to figure out how many children in Ontario are acquiring hepatitis B prior to adolescent vaccination. And what we showed is that when we compare Canadian-born children living in Ontario versus children that are not born in Canada or foreign-born Canadians, that the number was much higher among Canadian-born children. So their major risk factor for acquisition is going to be vertical transmission. However, we assume that we're universally screening all pregnant women. So there must be some other mechanism of which children are acquiring hepatitis B prior to adolescent vaccination. And these are just the other provinces that also only vaccinate in Ontario. And maybe I should just state that even though we are vaccinating in adolescents, even adolescents uptake is quite poor. So it's only about 70%, and it plummeted during the pandemic because of the lack of school age vaccinations by school nurses. So we're probably much, much lower. As a reminder, vaccination in infancy, so our typical measles, mumps, rubella, tetanus, diphtheria, pertussis, has a 90% plus uptake. So we're much lower in adolescent vaccinations. I'm going to go through a couple of cases through this presentation, and it's really just to show you sort of the things that I see in the community. And a lot of times they're not even in major centers like Toronto, they're often in other centers that don't have the same amount of specialty care. So I was introduced to a family, and this is what these folks were referred to me. And so the dad was actually positive, and his story goes as such. He was tested before he immigrated to Canada, and he knew he was hepatitis B positive. He was told he was hepatitis B positive. He immigrated, and then he went to a walk-in in his first couple of weeks in Canada and let the clinician know that he was positive for Hep B. As I mentioned, viral hepatitis is not necessarily well understood in the community. So that clinician actually vaccinated him for hepatitis B, and he sort of went on with his life. 5 years later, I saw him as a referral, and we did his testing, and I mentioned to him that he is in fact positive, and that although his child was born in Canada and his wife was negative, his entire family should be vaccinated and are at risk for infection because they didn't actually know that the dad was positive, or it wasn't well understood. So in fact, this child missed out on birth dose vaccination. And luckily, they were negative when we tested them at age 5, and they did receive their vaccine series at age 5, as did the mom or the partner. However, this would have been a perfect example of when universal screening in pregnancy failed because the mom was negative, and birth dose vaccination could have protected this child. And thank goodness they weren't infected, but that's not necessarily the case for many children. So I want to go through now a few things that we don't know. And there's an administrative database that many of you are probably familiar with called ICES. And even ICES can't necessarily fill the gaps in these data. So we don't actually know why Hep B DNA testing is not done in pregnancy. Is this a provider knowledge gap? Are they referred to a specialist, but they don't follow up, or the specialist can't get a hold of them? And then we really actually don't understand the full cascade of care, and it's something our group is actually going to start working on. We also don't know the number of eligible women who receive third trimester antivirals. So we don't know how well we're doing in fully preventing vertical transmission. We also don't know anything in Ontario about horizontal transmission. So household transmission, daycare transmission, caregiver transmission, we actually don't know. And then when it comes to pediatric care, we have done this ICES study, but it's probably greatly underestimating the number of children living with hepatitis B. And the administrative data can't actually tell us how many children get HBV who are born to a positive mom, and how many children get vaccination who are born to a positive mom. And unlike many provinces, this gap in Ontario is not filled because we don't have a vaccine database. So that would be a wonderful thing. And I know it's supposed to be coming, but many provinces are ahead of us in that way. The other piece is that we are still the destination province for many people who come from endemic countries. And we're only estimating the effect of immigration in a lot of our work, but we don't actually know how many people are immigrating with hepatitis B because we don't test during the immigration medical. So just as a reminder, in terms of infectious disease screening, we screen for HIV, syphilis, tuberculosis, but not hepatitis B or C. So how can we better serve pregnant persons with hepatitis B? Well, we really have a good handful of technical solutions to fill some of these gaps. So if we think about universal screening, we should be at the level of HIV universal screening, which is hepatitis B is lower at 93%, whereas HIV screening is 95%. So there's probably some education to do there around those screening. We could reflex test samples that are surface antigen positive for HBV DNA testing and hepatitis B e antigen testing. Other regions do this, other countries do this. And so that's a way to fill that 40% gap or overall 60% gap in the number of women who are not tested. As you're aware, each individual public health unit has their own way in which they follow up on positive infectious disease testing. And this can be challenging because it can lead to fractured follow-up. We also don't understand the cascade of care for pregnant women. We need to do that work. And we probably need to do more education in terms of primary care, OB care, and OB care around the need for follow-up. We could also co-localize care. So primary care and obstetricians could do more hepatitis B care to prevent that loss to follow-up when that referral to specialists goes out. Finally, just addressing the HBV plus birth dose vaccination, not knowing the caregiver status, and children being born in Canada who are acquiring hepatitis B, we should be keeping records of the moms that we know are infected and the children that we know are getting Hep B immunoglobulin. We don't have that vaccine database, which we really do need, but the major overarching message, if you take nothing else from my presentation, is that Ontario needs to move to birth dose vaccination for hepatitis B. Because even if we don't have universal screening in pregnancy, even if we have poor follow-up in pregnancy, universal birth dose and/or infant vaccination would fill this gap. And we've really shown that children in Ontario who are born in Canada are acquiring hepatitis B before they are vaccinated in adolescence. Okay, we'll take a quick learning break here. And so as Melissa mentioned, I did do a PhD in basic science. And so I think this is really inspiring and a little bit cute. So this is the grandfather. He says, "Look at what I got you. It looks like a bow." She says, "What is it?" He says, "It's usually something girls wear." He says, "When they do girl things." She says, "Awesome." Puts it on as a bow tie and goes to the lab. So I'm going to move on to hepatitis C now, and just to update you on hepatitis C, because so much has changed in the last 1 decade. Hepatitis C continues to be the #1 cause of morbidity and mortality in Ontario. So it leads to more years of life lost than any other infectious disease. This is a bit old on the right-hand side of your screen. This is from Canadian Liver Foundation. But what it really shows is that hepatitis C, if we don't do something about it now, it is a ticking time bomb. So it's going to lead to more liver cancer than we've ever seen in the past. As a reminder, it's a single-stranded positive sense RNA virus. It's enveloped, and there are many genotypes, but that becomes less and less important now that we have different types of treatment. And just to remind you about the natural history, so when people are first infected with hepatitis C, their viral load goes up and down and up and down. Their ALTs go up and down and up and down. And then 50% of people will cure this virus on their own. The other 50 to 75% will become chronically infected. And after that 3-month window, they will become antibody positive for Hep C. So we've got the acute stage and the chronic stage. So as per the Canadian guidelines, who should be screened for hepatitis C? Well, we have risk factor-based screening. Those are the activities listed here. We have medical risks that are listed here. And then there's the suggestion around birth cohort screening. So anyone born between 1945 and 1975 should be screened for hepatitis C at least one time if they don't have ongoing risk factors. But are we missing opportunities to screen? So we tend to be behind the US in terms of recommending screening opportunities. And the US has moved to screening all adults, so anyone over the age of 18 at least once, and all pregnant women. And these were based on many studies that show that the prevalence is going up around in younger folks because of the opioid crisis, and that screening pregnant women might be an opportune time to engage them in care. So just quickly, we have many modalities to screen for Hep C now, and a positive antibody test needs to be what's called reflexed if we are to minimize the gap from those lost to follow-up when an additional blood draw is required. So currently in Ontario, we're one of 2 provinces that does not reflex testing. So it requires 2 separate samples from an individual to get to that diagnosis stage. We do reflex genotyping, which is excellent. And in the community and the work that I do when we're doing mostly outreach among vulnerable populations, 2 blood draws is just not possible. So we use point of care testing to do antibody screening, followed by an immediate dry blood spot test, which has been available at PHO since 2017 for all of Ontario. And that decreases that gap of 30% of people who are lost to follow-up. So just to compare what's been going on with treatment in the last 5 years. In the past, only a few number of people were able to be treated. They needed really large teams, and they needed to be treated by specialists. They needed a lot of monitoring, and therapy was changed in response to the monitoring. In our current landscape of treatment, where their cure rate is 95% plus, solo providers can treat Hep C. In Ontario, we're so lucky. We can use what's called a limited use code or an LU code. So it's a prescription by an MD or an NP and an LU code. If people do not have advanced liver disease, they don't really need monitoring on treatment. Check-ins are nice. And we don't change treatment decisions, even around if people are not adhering to medication while they're on therapy. So what about women of childbearing potential? Well, this is data from the BC CDC. And what it shows is that women of childbearing potential, so those born after 1975, actually have a higher prevalence than men in that age cohort. And that's pretty unusual because men are more often to be users of injection drugs. And so this was really surprising when this data first came out. What this data also showed was that women of childbearing potential also are less likely to be treated for Hep C. And so if we think about what is this hepatitis C maternal-child continuum, well, there's a lot of different times when we can be intervening. So we could be intervening preconception, so treating prior to pregnancy. We could be treating in between pregnancies. Hepatitis C does affect maternal and child health. You can breastfeed with Hep C. And there's also some potential impacts to the infant. So currently we estimate that vertical transmission is about 5%. And at present, there's no way to intervene to prevent transmission. So the current screening paradigm for Hep C in pregnancy has traditionally been focused on identifying those with risk factors. And this comes from SOGC. But due to low screening rates, many regions and countries have adopted universal screening in pregnancy. Canada continues to recommend risk-based screening, but there have been multiple studies in Canada and other places that show that women may not disclose their risk factors, may be unaware of them, or may have had risk factors in the past, or even said they were at risk, but were not tested. So what are some of the rationales to move towards universal screening for Hep C in pregnancy? And as I mentioned, it's currently not one of the things that we do universally screen for. So if we were to move to universal screening, we could be aware and potentially improve maternal health. We could link women who are positive to care and treat them postpartum, so they are not positive during their next pregnancy. And importantly, if we don't test mom, we're not going to know to test the child and treat the child. And this is really important because we can now treat children easily as young as age 3. And currently there is no formal analysis of universal screening in pregnancy. And so we've done a little bit of this work, and I'm going to show that here. So just recently we finished a prospective screening program at London Health Sciences, which is a major academic OB program. It serves a lot of Ontario. And they'd implemented a universal screening program for 12 full months. These were done at times where blood work was already being drawn. So first prenatal visit, 28-week labs, or labor and delivery. And if a flag came up that the person was always already screened, the clinician could override this, or they could decide that they weren't going to rescreen. And so as we understand it, this is the first universal screening study done in Ontario. And the overall prevalence was 0.71%. And I just have the confidence intervals shown there. So we have now a true prevalence, at least in this region, of hepatitis C antibody. And the total tests were quite large. So it was an average of 481 tests a month, so close to 6,000 tests. And now we're evaluating this data to look at how many women had HCV RNA done, how many women were linked to care, where did they live, did they go to their appointments, and were they treated postpartum. So what we currently know, based on some of our different studies, is that some provinces are universally screening. So Saskatchewan is universally screening, and Alberta just switched to universal screening. And when we compare some of our data around risk-based screening to Saskatchewan, it's actually pretty close, universal to risk-based. And so now we've done this recent work where we show an overall prevalence of 0.71%, which is actually higher, if you might remember, than hepatitis B. Now, in terms of the cascade of care, we've also shown for Hep C, as we showed for Hep B, that many women are not tested for Hep C nucleic acid, which in this case is RNA, in that pregnancy. So we showed that only 56% of women in Ontario actually have a Hep C RNA done. And this is important because with the antibody screen alone, we would only know if people were exposed but not infected. Now, vulnerable women are very affected by Hep C. So many of you have probably seen the opioid-related morbidity and mortality data. And even prior to the pandemic, it was shooting up in Ontario, and it's only gotten worse during the pandemic. But women are more likely to exchange sexual services for being injected by another individual. So women are highly affected by the power imbalances in the way that they acquire drugs, in whether they have harm reduction supplies, how the drugs are prepared. And rates are increasing for Hep C among women of childbearing potential. And I showed you that they are less likely to be treated. Now, a really nice ICES study also showed that there's been a 16-fold increase in children being born to a person with opioid use disorder between 2002 and 2014. So it follows that the prevalence of Hep C is going to increase among pregnant women. And so we have to get past this dogma of, well, if there's nothing we can do to intervene in vertical transmission, why test? And I'll tell you why. So both maternal and infant health are complicated by hepatitis C, and we need to know if women are positive. If we don't test in pregnancy, we can't link people to care postpartum, and we can't test and treat the child. And actually, and unfortunately, it has been shown through another ICES study by Jen Fleming's group that most children are not screened for hepatitis C, even when the mom is known to be positive. So even though there are many unanswered questions, there are also opportunities to improve. So why isn't subsequent testing done? Again, we don't know, just like we don't know for hepatitis B, but is this a potential knowledge gap? Are people referred but they're lost to follow up? If we were to have that thing I mentioned, reflex testing, where the sample for antibody is used for RNA testing, we would eliminate this piece of the loss to follow up in the cascade, where only 56% of women are ever tested. What about transmission? So how does transmission actually occur? Does it occur in first trimester, second trimester, third trimester of the pregnancy? Does it occur labor and during labor and delivery? Well, we really don't know. But what we do know is that there have been some preliminary studies that have looked at actually treating women in pregnancy. And in those studies, 100% of children were negative for Hep C. And so the American guidelines for hepatitis C have now come out to say that, we should possibly consider treating women with DAAs or direct acting antivirals during pregnancy. And there's probably many pros to consider in this scenario. And then what about the pediatric piece? Well, we actually don't know how many children in Ontario have Hep C. Based on some of our modeling data, we think it's probably 1,000. But when we look at the major centers who do this work, like Sick Kids and CHIO and others, we do not have 1,000 children in care for Hep C management. However, if we don't test mom, we can't link children to care. And the best way to link children to care is in their well baby visits. So they're already getting vaccinations, well baby checks, mom's already coming in. And so to engage mom in treatment and in well baby visits and continue to follow the child till age 3 and treat them in primary care is probably our best bet to eliminate hepatitis C in Canada. We also need to think about pediatric treaters. So the same reasons why individuals have trouble getting to tertiary care centers for Hep C treatment, their children are also going to have those same issues around transit and structural and geographical issues, as well as stigma, which we can't forget to acknowledge. And I'm going to just tell you 2 cases where women were not engaged and they probably should have been. So the first is an individual that I cared for that had 4 children. And during the pregnancy of the last one, the OB provider told them that their viral load was not high enough to be treated. So this woman could have been treated preconception, but the providers that she had seen said their viral load was not high enough. And for those of you who are aware, if someone is positive for Hep C RNA, they're positive. The viral load really doesn't matter. Also, when we think about this population, we really want to be very considerate of those engaged in the justice system. And so we've been really successful to get blood work done during pregnancy while people are in the correctional system. And then through restorative justice programs, where moms are able to remain with their children, we can closely follow them through multiple mechanisms, which I'll discuss in a moment, to treat them postpartum after they're finished breastfeeding. So what's the best way to engage women in prenatal and postpartum follow-up? And for those of you who come from public health units, community care centers, community health centers, just to share some of the strategies we've used. So we get referrals from, for sure, traditional mechanisms like primary health care, the sexual health unit, OB, gynae, et cetera. But we also have an extensive street outreach program. And this is where we meet most pregnant women with Hep C. So we meet them in restorative justice programs and rehab and recovery programs, and we get to know them so that we can engage them postpartum and screen them, their children, and then link and treat. So although there are multiple access points, we have to make these extremely low barrier. So traditional in-person clinic care, I think it's a mechanism that doesn't work for most people. We work with many community organizations who help us to find individuals through agency work and community street outreach and OAT programs. We get to know the correctional folks, the folks who work in corrections, so that we can develop relationships and continue to connect with individuals in and out of the justice system. And I think for all of you who are members of a regulatory college, you can probably identify with me that our colleges have not kept pace with the fact that in order to reach these folks, we have to use non-traditional mechanisms. Like we have to be able to text, email. Most of these women will engage by text, but very few will pick up their phone. So we see that as just a central access point, and we often get self-referrals where people just call us, or friend referrals and partner referrals. So how do we better serve pregnant persons with Hep C? Well, vulnerable women have really not been the focus of specialized programs for hepatitis C. We need to be way more flexible in working with this population, and we need to have peer-led models. And what that means is individuals who have had a shared journey with pregnant women with Hep C. They could have been in a restorative justice program, they could have had Hep C themselves. And what we hear from women and peers and outreach workers is people might not be ready to engage right now, but we should not give up on them. They don't want us to give up on them. Even when people are screened in pregnancy, which again is not universal, follow-up is very poor. So right now we estimate that only 10% of women are actually treated postpartum. And one way to fill this gap would be Hep C reflex testing during the pregnancy. We really have an opportunity to prevent vertical transmission. Vertical transmission is the #1 reason for pediatric hepatitis C. So what does that mean? Well, let's do universal screening. To start, let's consider treatment in pregnancy. This would prevent any future transmission, and then link people to the other resources that they need, like OAT, planning for the postpartum period, because most people want to be with their children, and they're more inclined to enter these programs if that is the case. And then we can eliminate pediatric Hep C. We can do it in Canada, and we can do it soon. We have treatment now down to age 3. And if we just improve screening among pregnant women and children, then we can really change this cascade of care. And what I want to just mention about discussing the rationale with the parents or the mom is that a lot of women think that there's nothing that can be done for their child, so why screen? And so we really need to discuss that treatment is available, and that can really change the children's life trajectory, and they might never know they had Hep C if they're treated at age 3. I would like to thank the many individuals who have contributed to this work that I've presented here today, and I would be happy to take any questions.
I can start with the questions.
Okay.
There's one that came in. There's a comment that just says, "I'm shocked." I think a lot of audiences will agree that some of the items discussed today were very new to us. So thank you, Mia, for presenting that. We have a question about what would be potential barriers to implementing reflex testing in the province?
Yeah, thank you so much for that question. I think it's an anonymous question, but for whoever that was, thank you so much. And, you know, I must admit, so some of the barriers could be scientific, but they could also be logistical. So there's been a huge movement to move towards the reflex testing. So as an example, Quest Diagnostics in the US, which is a huge diagnostics company, has validated reflex testing. And then many provinces have moved to reflex testing and even removed reflex genotype testing to save on the cost of Hep C RNA testing. So if there's lab folks from PHOL on the call, please feel free to chime in. But as I understand it, one difference between Ontario and other provinces is simply the volume of samples. So the high number of volume and the need to strategically change the workflow. But from a scientific perspective, this has been shown through, honestly, decades that the change in viral load is at most 1 log if the sample were to sit in the fridge, let's say for 1 week, and be retested for Hep C RNA. Hope that answers the question.
Thank you. And I think this might be a related question, but if the goal is to eliminate viral hepatitis by 2030, why are we not including HBV and HCV within immigration testing? And is there a plan to change this?
Great question. So this has gone through quite a bit of stakeholder engagement. whether or not to include these tests. And by stakeholders, I mean folks who are newcomers or identify as folks who are immigrants from these endemic countries. And there has been a lot of pushback from the community of these individuals. So they are concerned, and perhaps rightfully so, that this may affect their ability to immigrate. And so I think in this day and age, we need to listen to our stakeholder groups and really carefully consider whether or not this is best for the population, or whether this should be downshifted to primary care screening, where so much other testing and investigations are required anyways. And so to my point about the primary care crisis, unfortunately, there has been a lot of pullback on providing funding for primary care providers to work with those who are new to Canada and need language support and things like that.
Thank you. And we have a question from who asks, is the HBV DNA, is there a cost for this test? Could the money be a factor for people, perhaps a barrier?
Oh, good question. Oh, it's okay. So there wouldn't be a cost to the patient. If people have a OHIP card in Ontario or not for Public Health Ontario testing, testing is free. So the cost is similar to a lot of the nucleic acid-based tests that are done at Public Health Ontario, but it's a systems cost. It's not a cost to the individual. And we should be doing it. So it's not a question of should we be doing it or not. It's a question of, is there a better way to fill that gap, such as reflex testing?
Thank you. And we have a question from who asks, if a young child is treated for Hep C cured, would they not still have a positive Hep B antibody later in life?
So if a child is diagnosed with Hep C, and diagnosed meaning they are antibody positive, which is exposure, but they're actually RNA positive. So they're actively infected with Hep C. Yes, for sure, if they are cured of their Hep C, they will be RNA negative and they will remain antibody positive for life. And that would be the case as every single individual in Ontario who's treated for Hep C. I think to your point, it's a bit of a problem because new providers might continually screen them for antibody and they'll always come back positive. And so we're really passionate about engaging our patients so that they can advocate and tell their providers that they know they're going to be antibody positive. And if they want to be tested, they should be tested for RNA if they have risk factors.
Great, thank you for clarifying. And we have a question about the 93% prenatal screening rate in HBV. Were most of the individuals screened during the first trimester? And if they are screened in later trimesters, could the late screening impact their ability to do follow-up nucleic acid testing?
Yeah, really good question. And just to point out, as I mentioned, that HIV testing is 95%. So it by no means is testing poor. It's just not universal, and it maybe not be where it should be. And so I guess to answer your question, we don't know currently where people are tested. We're doing this work now to truly build out the cascade of care without just using PHOL data, which we were so grateful for our collaboration on this work, but to actually follow individuals through the cascade of care. So it is a potential, and we will know soon. The other piece is just around that follow-up, right? So do they ever get treatment and cure? And even if they're tested at labor and delivery, that doesn't mean the HBV DNA couldn't have been sent off, right? So those are still individuals that have no prenatal care, which happens sometimes, no prenatal care until labor and delivery, but that HBV DNA should still be sent off.
Great, thank you, Mia. And I'm just gonna pass it back to Melissa now.
So Mia, thank you so much for this wonderful presentation. It was really exciting, and I saw a lot of the comments in the box as well, kind of giving kudos to you in bringing up such an important topic. I just wanted to share a very quick story as well from when I was training in the US. So anytime in the ED there, or even in the inpatient wards too, if there were patients who didn't have their Hep B vaccination, or if they hadn't had their screening done, as you had mentioned that it was part of the US, the infectious diseases team, when they had a moment, would go and actually do education and try to support having that individual make a decision to either start their vaccinations or to get screening done. And I thought it was really wonderful to just see that and to even participate in that. So I don't know if it's something that we're doing here in Ontario, but it did work in the US. I mean, not for everyone, but it did bring some individuals on board, and it was really great to see. I think there are maybe a couple more questions in the box before we have 1 minute left. So the last question, what are the serology testing recommendations for infants born to HCV positive mothers, anti-HCV, or should HCV RNA be completed sooner?
So there are some recommendations. So there are 2 ways to screen infants. So serology at 18 months, so anti-HCV, and that's because there could still be passive transfer of mom's antibodies, so not to do antibody screening before 18 months. However, RNA screening could be done at 4 months or at 6 months. Typically, the barrier there is that the child is so young that it's very anxiety provoking for the parents to take the child at that age. We're doing some work around validating dried blood spot testing for infants, so that could be an exciting avenue. But you could test children as young as 4 or 6 months. And what I would say you should think about in that decision-making process is how likely is this family to be lost to follow-up. So earlier testing might be appropriate if this family has a high risk of loss to follow-up. And sorry, I know we're running out of time, but I just want to say a lot of these children do end up in child services. And so that's probably one of the main reasons why a lot of them are not tested. So there's some work to be done in that sector as well.
Thank you so much, Mia. And I know there's more questions in the chat, in the Q&A box, but we won't have time to finish them up today, but we'll look into answering them for you as well. So just to wrap up today's PHO round session, I would like to thank Dr. Bionde for presenting. I'd also like to thank everyone who joined us for today's session. I hope you learned a lot. I certainly did. You can expect to receive the brief and anonymous PHO Microbiology Rounds survey for today's session. Please try to complete this to help us improve our programming, and also just mention some other topics you might be interested in. And then lastly, to access past PHO Microbiology Rounds presentations and view confirmed upcoming sessions, please visit the PHO website, head to Education and Events, and click on Presentations. Thank you so much to everyone, and have a wonderful day.